Thank you very much. It's a great pleasure to be today with Ulster Global in this fascinating meeting. Today, I'm going to present to you our story about Ulster syndrome discovered in small village in Palestine. I may try to stop video just to make sure that the connection is stable, if you don't mind. So, I'm Dr. Reham Khalaf-Nazzal, a clinician and an academic at the Faculty of Medicine in the Arab American University in Jenin, together with my colleague, Dr. Baple, who's a consultant geneticist and a clinical senior lecturer at the University of Exeter. We're going to present our work about Ulster syndrome in Palestine. So please, Dr. Imma, go ahead.
Thank you, Reham. So first of all, we thought we would tell you how the program came about in the first place. So my name is Emma Baple, as Reham said, and I lead the Rare Disease Research Group in Exeter with my colleague, Professor Andrew Crosby. And the focus of our work is on translational community genomic research programs with clinical colleagues like Reham, but also across other parts of the world. And we do our work in partnership with the communities that we work with. So the oldest of our programs is about 20 years old now, and that's with the Amish communities in North America. But we've subsequently worked with colleagues in Pakistan and Oman. And more recently, about 4 years ago, we formed a collaboration with Reham and colleagues in the West Bank. And that came through one of my colleagues in the clinical genetics department in Exeter, Professor Peter Turnpenny, who I think is with us today. And Peter had worked with Palestinian families over in the West Bank for about 10 years. And he introduced me to Reham and explained that there was a great need for genetic services in the West Bank. Now, the work that we do is initially to find the genetic cause of disease. So we work in communities where there has been an event. So they usually come from large genetically diverse populations, but then there's been what we call a bottleneck event. So that means there's been a migration or an episode of geographical isolation, which means that certain gene changes become enriched within those communities. So we end up with what we call founder variants, or founder mutations would be the older fashioned term, underlying certain conditions. And that's what we're going to tell you about, a founder variant in the West Bank that underlies Ulster syndrome in somewhere in the region of 40 different patients. Next slide, please, Reham. So our work does not just end at finding the genetic cause of disease. The reason we call them translational community genomic research programs is because we take that genetic cause of disease and we go to understand the mechanism of that disease and what's going wrong inside the patient. And we do that because we want to identify treatments, we want to look to refine clinical management programs, and we also work with our colleagues to put in place educational programs for the community about those disorders and the patients and the families, but also for the clinicians, so they know about the conditions that are in the patients that they serve, so that they can look out for them. We also help our colleagues to set up diagnostic genetic testing locally, and we work on knowledge exchange so that our colleagues are able to take the knowledge and the information that we gain together and use that information locally to make sure that genetic services expand and grow to serve the patients there. I wanted to just take the word community and explain to you a little bit more about what I'm talking about. So community can describe any group of people whose genetic makeup's been influenced somehow by geographical isolation or marriage patterns. But that's not the important bit, really. What is community genomics? It's the art and science of the responsible and realistic application of health and disease-related genetics and genomics, knowledge and technologies in humans. And it's to the benefit of the individuals therein. That's the most important bit. It's multi and transdisciplinary, and it aims to maximize the benefits for those individuals whilst minimizing the risk of harm and respecting the autonomy of those individuals and ensuring equity. I'll pass back to Reham now.
Thank you very much, Emma. So today we'll present to you Stories of Hope, Stories from Palestine project. This is a translational genomics project with our colleagues at Exeter University. You can see in this photo Professor Peter Tenpenny leading with us to one of the field visits where we have been heading to Jericho to visit one of the families. Also, you can see that we are in contact and in communication with our colleagues in the hospital to discuss the genomic findings. These are several field visits and communities with whom we work together. And the Exeter team is joining frequently us, and this was mainly before the COVID-19 era, to perform the research clinics locally. So they are also in direct communication with patients and their families. This is a bilateral exchange, and this is me with colleagues from Exeter. So Stories of Hope, through the past something like 9 years, have been working to establish a system of referral. We have a very well-established clinicians network for referral of patients who need genetics testing. We also have a community outreach clinic where patients and their families can present directly to us. At the Arab American University, we have a molecular genetics laboratory that works in collaboration with colleagues from Exeter University Medical School to find the genetic diagnoses and establish testing. Recently, we have established a community educational modules through which we try to educate community university students and patients and their families about the nature of genetic diseases. So first, I'm going to present about the healthcare system in Palestine, which has been mainly composed of 3 major partners, with the Palestinian Ministry of Health providing the primary and the secondary healthcare services. The other partner is the United Nations Relief and Works Agency for Palestinians living in refugee camps, where primary healthcare services are provided. Non-governmental organizations help in providing primary health care, and particularly in Jerusalem, they're providing secondary and the only available tertiary health services in the region. The private sector is a newly joining sector in Palestine, and it's taking more and more role in the healthcare system. It's important to notice that the direct connections between the healthcare services and academic institutions is not very well established. Although there are some communications, the relations need cementing, and the educational system and the academic institutions need to have to know actually what are the major challenges faced by the healthcare system. So there is an obvious need to cement the relationship between the academic institutions and the healthcare system. However, we totally understand that budgets for research are very limited, and this is going to be always an issue. So one would ask, why Stories of Hope is in the north of the West Bank, and particularly is in Jenin. Actually, Jenin is the furthest city from the only clinical genetics service in Jerusalem. Jenin, governorate and locality, is a large locality. Actually, the city itself is small, but is surrounded by something like 250 villages. This, with Tubas, gives the second biggest locality in the West Bank. Added to that, Jenin and other cities in the north of Palestine had the lowest patient bed per 10,000 population in the West Bank. And this is really important. This has been documented by the annual health report for 2020 by the Palestinian Ministry of Health. The Arab American University lies in the heart of villages and is surrounded by so many villages. So it's an excellent provider for those kind of community services. The Arab American University is very interested in establishing networks with the healthcare sector and the community. We are very pleased back 2 years ago that we have signed a memorandum of understanding between our colleagues at Exeter University Medical School and the Arab American University. Also, we're very pleased that we've been in communication with a local clinician network, and even in this photo, one can see us in the ICU helping in the diagnosis of a very young neonate with molecular testing. Today, Stories of Hope is not only restricted to Jenin. We have recruited patients from almost all cities in the West Bank and even from Gaza Strip. Palestinians living in Jordan and in United Arab Emirates have been addressing to us asking for help. In total, we have around 150 families enrolled. We've been working towards 80 molecular diagnoses serving 300 patients, and diagnoses have directly informed patient care. And today, I'm going to talk to you about several families with Alström syndrome in one of the Jenin villages. This is Dr. Fida Hijawi, a brilliant pediatrician from the Palestinian Ministry of Health Clinics in Jenin. Dr. Fida is co-founder of Stories of Hope Clinical Network, and she's been helping us in directing us towards communities in need of diagnostic support. So in several instances, including the village of Alström, we've been really able to find, to arrive to communities in need of help. In this family pedigree, we can see the first families enrolled in the project for genetic testing in Alström syndrome. 2 brothers and their sister and their cousins were the earliest patients to get tested, and actually jointly with our collaborators in Exeter University, we have been able to perform sequencing and identify the exact cause. Later on, we have identified other Alström patients from other stems of the family. Going back to the village, this is a mountainous village with amazing landscape and views. And initially, all Alström patients identified were from what is known as the eastern district of the village. So it is very well known that this eastern district of the village is where all Alström patients are. Actually, this is around a water spring. So if you ask anybody from the village, they will tell you, oh yes, Alström is very common around the water spring. However, we have identified Alström patients in the village who are coming from different districts of the village. These are examples of other Alström patients. So looking to the pedigree on the right side, one can find 2 sisters affected with Alström syndrome, and among in the family, there is the consanguinity is very common. However, Alström in this village is not only restricted to consanguineous marriages. In this pedigree, one can find an affected patients for parents who are not consanguineous. We've been trying actually to understand if there is any relation between the families. But finally, and so far, we have realized that Alström patients originate from 4 different families living in the same village since at least the Ottoman era in the 16th century. And they're not restricted to only one family. About the clinical presentation, we have patients enrolled in genetic studies ranging in age from 3 years to 40 years. At least 4 patients have died in their early 30s in the past 10 years, and both males and females are equally affected. Patients, almost all of them, present early in life at the age of 3 months with wobbly eyes, difficulty in vision when seeing the sun, photophobia, is evident around the age of 2 years. Obesity is obvious around the age of 5 years. Unfortunately, progressive visual loss leads almost to blindness at the age of 5 years. And diabetes, type 2 diabetes, is evident around the age of 7 years, with sensory neuronal healing loss coming later around the age of 15 years. Later, fatty liver, chronic kidney impairment, and multi-system involvement around the age of 20 years is evident. So between 15 and 20 years, the clinical course is quite complicated for those patients, with loss of appetite and weight loss prevalent after the age of 20. This is an example of a patient who was diagnosed with Alström at the age of 22 years with pancreatitis, actually. He had severe acute pancreatitis with destruction of his pancreas, and he's on pancreatic enzyme replacement. So far, cardiomyopathy is not yet reported. And the oldest screened patient for cardiomyopathy was 26 years. There is significant delay in the diagnosis of the disease or the detection of complications, and unfortunately, death in mid-20s is common. So those patients have the management for their diabetes, their liver and kidney complications taken part by the Ministry of Health outpatient clinics and hospitals. Ophthalmology review is provided by St. John Eye Hospital in Jerusalem, quite distant for patient, and this is why this is not very frequent. Diet and exercise management is not provided and is not available in the village, unfortunately. And there is evidence of appearance of multi-organ complications between the age of 16 and 20 years. Whether this is the natural course of the disease or is related to the transition of care between pediatrics and adult care services is not clear to us. By the time the patients need to enter to school, unfortunately, they can't attend regular schools. So they attend visually impaired school for visually impaired children in Jenin. So there is a transportation issue. After school age, there is no specific organization to support education, entry to the job market. And this is further complicated by the progression of complications in the disease. We're happy that we have one adult patient who's preparing for university entry exams. So they're attending the school and they're preparing for this exam. And we hope with time, the number of patients who can attend universities would increase. So in collaboration with our colleagues in Exeter University, we've been able to test for the mutation, and we identified a homozygous mutation in the ALMS1 gene. This is a frame shift found variant. The same variant is detected in all patients tested so far. And we're actively working with the community, educating and spreading brochures and printables about hereditary diseases and the mode of inheritance. In addition, we're providing genetic diagnoses and carriers testing free of charge for the patients and their families. We're very excited with our relation with Alström Global. And we're very happy to be with you today. Through Ulstrom Global, we're pretty sure we'll be able to optimize care for these patients. So we hope we can support the community and hold community support events. Our patients are and their families are very happy to see you, actually. And I'm very pleased that we have one of our patient mothers today attending with us, and very happy to know more and more about the disease and about you. We hope through joining Ulstrom Global, we can help in Ulstrom syndrome patient registry. And we'll be working towards the translation and the validation of Ulstrom syndrome medical handbook to Arabic. We will aim at training a local clinician to the complex care of Ulstrom patients, hoping all of those efforts will help in optimizing care and will give the needed background for therapeutic interventions. Finally, I would like to thank you all for being here with us, listening about our story. My sincere thanks to patients and their families, and to Ulstrom UK and Ulstrom Global. Our gratitude to Dr. Fida and Ministry of Health, to the Municipality of Jaba, and our collaborators and colleagues in Exeter University Medical School. And thank you very much.
Reham, do you mind moving to the last slide for me?
Yes.
We wanted to also just introduce this course that we have. So the community genomic programs that we run with Reham and others, we created a course that was funded by the Medical Research Foundation, who asked us to share what we do in an educational format for families and clinicians and communities, so they could learn a little bit more about how translational research in genomics can deliver health, social, and scientific benefits for communities. So it's aimed at everyone. It's free to access. And if you want to learn a little bit more about the sorts of work we do, then it's a continually running open online access course, and you'd be welcome to join that. And it's facilitated by our team. Thank you for listening to us both.
Okay, can you hear and see me? Catherine, perhaps you can tell me if you can.
Yeah, we can.
Yes, yeah,
Okay,
can see you and
perfect,
hear
thank
you.
Yeah, so Reham and Emma, thank you so much for that fascinating presentation. I know we've kind of only recently managed to meet up, but I guess we've got lots and lots of questions to ask you. And work is just fascinating. So a huge thank you from all of us. I'm going to start off with a couple of questions that are in the chat box, and then I'll probably move on to see if Pietro and Tim have any specific questions for you too. So one of the questions that has come up through the Q&A from Malin, who's in Sweden, is, do you know how many patients are affected in the Palestinian territories? So that's a question for either of you.
Yes. So in that particular village, the municipality estimates an approximate number of 40 patients. Actually, we're in contact with pediatricians and the geneticist in the West Bank to check if we have other Ulstrom patients from other parts of the West Bank or Gaza.
Okay.
In our studies, we have enrolled so far 15 patients, and the enrollment is ongoing.
Okay. Thank you very much for that. I think that's kind of answered, and Catherine's going to put that in the chat box too, or the Q&A box. Again, there'll be many questions that people go away with and want to come back and ask us, that's fine. The next presentation is going to be Professor Tim Barrett, but meanwhile, I think Tim has a couple of questions too. Is that Tim?
Thank you, Anne. Can you hear me? Okay.
Yes.
Okay. Reham, Emma, thank you so much. That was such an interesting presentation. And I can only admire the work that you're doing in Palestine with these families. It's just fantastic. So thank you so much for sharing. My question really is what can we do? How can we help? We've obviously got some expertise here with children's doctors, eye doctors, heart doctors, etc. What is it that you need most we could help? Because maybe we can find some crowdfunding method to have a remote clinic advice to support you as clinicians in the work you're doing. What would help most? Because I'm sure I could speak for my colleagues that we would love to share our expertise, and that maybe that there are some relatively non-complex interventions that could help improve the outcome for these children. If you could guide us as to what we can help with.
So yes, thank you very much for your enthusiastic support. Actually, in any care point one can touch, there is an immediate need for help. And maybe the one that comes on top of the list is training a local clinician. So Dr. Fida is very pleased to get training and to train because she's a community pediatrician who first identified those patients, and she's very keen, we've discussed this, and see she's very keen to then train the general practitioner and pediatrician from the village so they can closely follow up patients. We've been discussing actually the dream of establishing the first Ulstrom clinic in the West Bank. This is a dream, but I'm pretty sure we can further do that. We've touched on the need for patients to learn more about the syndrome, because when you go to the families and you say, yes, we know what this is, and then you have to explain to them this is genetics, mutations, and all of this, they would okay, there is a progressive nature of the disease that they need to learn about. And this is why translating the medical handbook is going to be of great help to them, and translating the animation is going to be of great help to them, I imagine.
Thank you, Reham. And I guess to give one example, you talked about one of your patients who had acute pancreatitis, which of course we have seen in UK patients with Ulstrom, often related to very high triglyceride levels. And so therefore once a year, we do an annual review of blood tests. And actually, Emma, with the help of Exeter's clinical chemistry laboratory, so Tim McDonald and others,
Yes.
he's very helped us to get home blood testing monitoring.
Yes, so
and
great.
on a finger prick, as you know, and he can check triglycerides on that. So as a relatively simple intervention, if we could support your families to get an annual blood test, something like triglyceride measurement might help anticipate and maybe prevent some cases of pancreatitis that you're describing. So that's just one small example where it would be lovely to work with you and try and help if we can. Yeah.
Professor Barrett, do you think we could perhaps organise a meeting away from this with Reham, myself, and perhaps Tim McDonald as well, so that we could have a look at what we might be able to do?
Yes, I'd love to. I think we should do it through Ulstrom Global, and
yes,
I'm
absolutely.
sure that Anne help facilitate that meeting. But I'd love to look at some practical ways
Exactly.
to support you. It'd be really nice.
That would be really wonderful, and I think that's what we were hoping would come out of today. So that's fantastic to hear.
Brilliant. Thank you very much. As I say, I know people sometimes have questions afterwards and we'll gather those together, but that sort of connection is kind of exactly the aim of some of the work of Ulstrom globally, so people can get together and collaborate, and hopefully we can offer both facilitation and a platform to do that. So thank you very much to both Reham and Emma.